Welcome to our deep dive into rapidly progressive osteoarthritis of the hip, or RPOH. This rare and aggressive form of osteoarthritis is characterized by swift deterioration of the hip joint, often leading to severe pain and disability within a short period. Unlike typical osteoarthritis, RPOH can progress so quickly that it challenges both patients and clinicians. Early detection and intervention are crucial, as delayed diagnosis can result in significant bone loss and complicate surgical outcomes. In this video, we'll explore the latest understanding of RPOH, focusing on early diagnosis, risk factors, and targeted interventions that can make a real difference in patient outcomes. Early diagnosis of RPOH is a clinical challenge due to the lack of unified guidelines and standardized criteria. The disease can cause rapid joint space narrowing, and in some cases, destruction of the femoral head and acetabulum within just 6 to 24 months. This rapid progression limits the ability to track changes with sequential radiographs in the early stages. If not caught early, extensive bone defects can develop, leading to poor outcomes after hip replacement surgery. That's why recognizing the earliest signs and understanding the risk factors are essential for preventing irreversible joint damage. RPOH was first described as a condition where joint space narrows by more than 2 per year or more than 50% within a year, without other causes like infection or inflammatory disease. Some definitions also include rapid bone loss exceeding 5 per year. These criteria require at least 12 months of follow-up, making early diagnosis difficult. Currently, there are no definitive criteria for diagnosing RPOH in its initial stages, highlighting the urgent need for new guidelines and tools to help clinicians identify the disease before significant damage occurs. Several classification systems have been proposed to describe the progression of RPOH. Some focus on the duration and severity of chondrolysis and bone loss, while others use radiographic findings to grade the disease. For example, one system classifies RPOH into types based on whether there is joint space narrowing alone or with femoral head destruction within 12 months. Another system grades the disease by the extent of joint space loss and femoral head deformation. However, none of these systems fully capture the nuances of early-stage progression, emphasizing the need for more precise classification in the first year after onset. One of the most striking features of RPOH is the sudden and severe onset of hip pain. Patients often report intense pain that appears abruptly, even when the hip looks normal on X-rays. This pain is usually worse at night and can significantly disrupt sleep and daily activities. Unlike the gradual discomfort seen in typical osteoarthritis, RPOH pain is acute and rapidly worsens, serving as an important early warning sign for clinicians to investigate further. The early stages of RPOH, patients often retain a normal passive range of motion in the affected hip. However, active movements, especially those involving weight bearing, can trigger excruciating pain. This combination, normal passive motion but painful active motion, is a hallmark of RPOH and helps distinguish it from other hip disorders. Recognizing this pattern is key for early suspicion and further diagnostic workup. Early radiographs in RPOH may show only subtle changes, such as minimal joint space narrowing and mild subchondral sclerosis, with a notable absence of osteophytes. These findings can be easily overlooked or mistaken for normal aging or mild osteoarthritis. However, follow-up radiographs taken a few months later may reveal rapid progression, making serial imaging important for patients with unexplained hip pain. Computed tomography (CT) can detect partial destruction of the femoral head earlier than plain radiographs, while magnetic resonance imaging (MRI) is even more sensitive. MRI may reveal bone marrow edema and abnormal signal intensities in the femoral head and neck, indicating inflammation and early joint damage. These advanced imaging techniques are invaluable for distinguishing RPOH from other hip conditions and for detecting early changes before they become obvious on X-ray. Distinguishing RPOH from other rapidly progressive hip diseases is critical. Conditions like subchondral insufficiency fracture, SIF, osteonecrosis, and typical osteoarthritis can present with similar symptoms. However, RPOH is unique in its pattern of joint space narrowing followed by femoral head destruction. MRI findings and clinical features such as the pattern of pain and range of motion help differentiate RPOH from these other disorders, ensuring appropriate management. POH primarily affects older adults, with women being at higher risk than men. Another significant risk factor is spinopelvic malalignment, which refers to abnormal alignment between the spine and pelvis. This misalignment can increase mechanical stress on the hip joint, accelerating cartilage and bone damage. Understanding these risk factors helps clinicians identify patients who may benefit from closer monitoring and early intervention. Spinopelvic alignment involves several anatomical parameters, including pelvic tilt, sacral slope, and lumbar lordosis. When these are out of balance, the distribution of forces across the hip joint changes, increasing stress on specific areas. Studies have shown that patients with RPOH often have increased posterior pelvic tilt and reduced lumbar lordosis, which may contribute to rapid joint destruction. Evaluating these parameters can provide valuable insights into disease risk and progression. At the cellular level, RPOH is marked by increased activity in the synovial tissue, including hyperplasia and infiltration by immune cells like macrophages and T lymphocytes. These changes resemble those seen in rheumatoid arthritis and suggest that inflammation plays a central role in joint destruction. Understanding these cellular mechanisms is key to developing targeted therapies that can halt disease progression in its earliest state. Several molecular pathways contribute to the rapid destruction seen in RPOH. Elevated levels of matrix, MMP3, and pro-inflammatory cytokines such as IL-1 beta, IL-6, and TNF-alpha are found in affected joints. These molecules drive cartilage breakdown and stimulate osteoclasts, leading to bone resorption. The interplay between mechanical stress, inflammation, and molecular signaling creates a vicious cycle of joint damage. Cartilage matrix fragments generated by abnormal mechanical stress act as danger-associated molecular patterns, or DAMPs. These DAMPs activate toll-like receptors in the NLRP3 inflammasome pathway, leading to the release of more pro-inflammatory cytokines and further joint destruction. This cascade amplifies inflammation and accelerates the progression of RPOH, making these pathways promising targets for early intervention. Identifying reliable biomarkers is essential for early diagnosis of RPOH. Elevated serum MMP3 levels and specific bone turnover markers have been associated with early femoral head destruction. Additionally, evaluating spinopelvic alignment parameters can help predict which patients are at risk for rapid progression. Combining biomarker analysis with imaging and clinical assessment may enable clinicians to intervene before irreversible damage occurs. Most patients with RPOH receive nonsteroidal anti-inflammatory drugs to manage pain in the early stages. Some may also be treated with medications like alendronate or vitamin D analogs, but these have shown limited effectiveness in halting disease progression. This underscores the need for therapies that target the underlying mechanisms of joint destruction, rather than just managing symptoms. Emerging strategies for early intervention focus on correcting spinopelvic malalignment and inhibiting key molecular pathways. Therapeutic exercises, postural adjustments, and even surgical correction may help reduce abnormal mechanical stress on the hip. On the molecular side, inhibitors targeting the NLRP3 inflammasome and pro-inflammatory cytokines are being explored as potential therapies to prevent joint destruction in the initial phase of RPOA. Several experimental drugs are under investigation for their ability to block the NLRP3 inflammasome pathway or inhibit key cytokines like IL-1 beta and IL-18. JAK inhibitors such as tofacitinib have shown promise in reducing inflammation and preventing joint destruction by targeting the IL-6-JAK-STAT3 axis. Ongoing research aims to validate these approaches in clinical trials and bring new hope to patients with RPOA. While significant progress has been made in understanding the pathogenesis of RPOH, many questions remain. Further research is needed to clarify the cellular and molecular pathways involved in rapid joint destruction, identify reliable biomarkers for early diagnosis, and develop effective targeted therapies. Collaboration between clinicians, researchers, and patients will be essential to advance the field and improve outcomes. Summarize: rapidly progressive osteoarthritis of the hip is a rare but devastating condition that requires early recognition and intervention. Key features include sudden severe pain, rapid joint space narrowing, and risk factors like spinopelvic malalignment. Advanced imaging, biomarker analysis, and a deeper understanding of molecular mechanisms are paving the way for earlier diagnosis and more effective treatments. Staying informed about these developments is crucial for anyone involved in hip health. As our understanding of RPOH continues to evolve, the future holds promise for earlier detection and more personalized interventions. By integrating clinical assessment, advanced imaging, and molecular diagnostics, we can move closer to preventing irreversible joint damage and improving quality of life for patients. Ongoing research and innovation will be key to unlocking new solutions in the fight against rapidly progressive hip osteoarthritis.